Okay, I just want to reemphasize that this presentation will be live streamed on YouTube and on our various social media platforms. So we are already starting the live stream. So Professor Dr. Omar, you have the floor.
Okay, thanks. I will start now, okay?
Yes.
Management of chest trauma in the African setting. Agenda of this webinar, we will talking about introduction, epidemiology of chest trauma in Africa, the challenges and the consideration, management strategy, conclusion. Introduction. The devastating impact of chest trauma in Africa. Chest trauma, injuries to the chest wall, lungs, and the major blood vessels, is a significant public health issue across Africa. It contributes greatly to morbidity and the mortality rates, with far-reaching consequences. This presentation will explore the impact of chest trauma in Africa, along with the challenges and solutions. Chest trauma is second leading cause of death worldwide, disproportionately affecting young people in Africa. WHO, the World Health Organization, identifies chest trauma as the second leading cause of death from injury globally. However, mortality rates are significantly higher compared to the developed regions. The heartbreaking disparity is caused by a lack of resources, like trauma centers, trained medical professionals, and vital medical supplies. Disparities in access to trauma care. There is a research paper talking about this point. Disparities in access to trauma care significantly impact patient outcome. People in rural areas often have far less access to well-equipped trauma centers and specialist medical professionals compared to urban areas, as highlighted in the research paper. Disparities in access to trauma care in Sub-Saharan Africa, a narrative review by Alauddin et al., 2022. Socioeconomic factors and the pre-existing health condition can make it harder for some individuals to receive proper care. A very recent study published in PMC Emergency Medicine in 2024 by Alauddin et al. Believed in mortality rates and the predictors of death from chest trauma across Sub-Saharan Africa. The study titled Mortality of Trauma, Chest Injury, and its predictor across Sub-Saharan Africa, systemic review and meta-analysis found a bold mortality rate of 9%. Several factors were identified as influences this number, including age over 50, delayed admission to a medical facility, presence of injuries to head, neck, spine, comorbidities, pre-existing medical conditions, need for ICU care, injury severity score. Unique challenges in Africa. While the previous slides highlighted the devastating impact and disparities in chest trauma care, we will dive deeper in the specific resource limitations that create significant challenges. Limited access to advanced equipment, essentials, tools like CT scanner for detailed imaging and the ventilator for respiratory support are often scarce or unavailable in many African healthcare facilities. This can hinder accurate diagnosis and limit treatment options for critically ill patients. Shortage of specialized personnel, trauma surgeon with expertise to handle complex chest injuries are in short supply across Africa. This places a heavy burden on available medical professionals and can lead to delay in critical interventions. Inadequate blood product and medication. Maintaining a sufficient supply of blood product for transfusion and essential medication for pain management and infection control is often a struggle. This lack of resources can further complicate treatment and compromise the outcome. These limitations necessitate adapted strategies. Due to this resource, healthcare providers must employ different approaches to chest trauma management. This webinar Again, welcome everyone. I would like to extend a special welcome to the doctors, nurses, paramedics, and the other trauma team members joining us today from across Africa. We recognize the vital role you play in caring for patients with chest trauma, leading cause of death and disability on this continent. This was not specifically designed for you, healthcare professionals working in Africa. We understand the unique challenges you face in managing chest trauma cases. Over the next hour, we will provide valuable insights and equip you with effective strategies. This knowledge will help you better anticipate and diagnose chest injury in your patients. Resource adaptive strategy will explore effective management strategy, especially tailored to resource limited setting. We will discuss how to adapt best practice to your environment, ensuring you can deliver the best possible care even with limited equipment and personnel. Collaboration and public health will highlight the importance of collaboration between healthcare professionals and public health initiatives. By working together, we can improve access to care, raise awareness, and ultimately save lives. By the end of this session, you will be equipped with deeper understanding chest trauma in Africa, along with practical strategies and the importance of collaboration. Epidemiology of chest trauma. High burden of chest trauma in Africa. Comparing causes of chest trauma. In Africa, RTA, road traffic accident, and violence as major contributors. In developed countries, briefly mentioned falls, sports injuries. Limited resources and the higher mortality, limited access, as we called previous, higher mortality rate. The key points: high prevalence, unique causes, limited resources, higher mortality rate compared to developed. Challenges and the consideration for chest trauma management in Africa. The lack of readily available advanced equipment in many African healthcare facilities, example, CT scanner for detailed imaging, chest tubes for drainage of air or fluid from chest cavity, mechanical ventilators for respiratory support, limited workforce creates management gaps, the shortage of specialized healthcare personnel in many African regions, trauma surgeons for complex surgeries, critical care specialists for intensive care management, trained nurses for skilled patient care, essential supplies like blood, pain management medications, antibiotic for preventing infections, pre-hospital care and the transport challenges, limitation in pre-hospital care systems in some African settings, limited availability of ambulance and the trained paramedics, poor road infrastructure, hindering timely transportation. Power issues disrupt critical care. The potential impact of unreliable electricity on critical medical equipment, disruption of life support, data loss and system errors, equipment damage, safety risks, consequences for patients, increased risk of death or complication, delayed treatment, psychological distress. Summary of challenges: limited resources like equipment, personnel, medication, pre-hospital care, and the transportation limitation, unreliable electricity supply. Management strategy for chest trauma in this situation. Adapting care to resource-limited setting. In Africa, healthcare providers face a unique challenge. Managing complex medical conditions like chest trauma with limited resource. However, this also presents an opportunity to develop innovative and effective strategies tailored to their environment. Clinical expertise. Since advanced imaging techniques like CT scan may be limited, clinical assessment skills become even more critical, relying on through physical examination, detailed patient histories, focused use of available diagnostic like X-ray, ultrasound is essential for accurate diagnosis. This emphasizes the importance of ongoing training in physical examination techniques for healthcare professionals, prioritization and resource allocation. Due to limited resources, we need to prioritize the interventions. Patients with the most urgent conditions and those who can benefit most from the available tools and the medication should be treated first. This ensures the most effective use of scarce resources. For example, a patient with life-threatening pneumothorax collapsed lung might require immediate chest drainage, even if no diagnostic tool cannot be performed initially. Adapting procedure. When necessary, healthcare providers may need to consider alternative techniques for essential procedure. In situation, if there is a chest tube unavailable, a simpler chest drainage method like needle thoracostomy might be used. This ensures life-saving intervention can still be performed despite limitations. Benefits of adaptation. By tailoring management strategy and adapt their approaches, healthcare in Africa can deliver the best possible care. Within the constraints of the continued training. Sorry. The importance of the golden hour. The first hour after a traumatic injury is considered the most critical period for successful intervention. During this time, the body is still in a state of shock, and the promote medical attention can significantly improve the chances of survival and minimize the long-term complication. Unfortunately, resource limitation can sometimes create delay in reaching definitive care. However, in this situation, early intervention initiated as the first point of contact can make a substantial difference. Strategy for early action training, highlighting the importance of the golden hour during a training program for healthcare professionals can instill a sense of urgency in initiating basic life support like airway management, controlling external bleeding. Communication, effective communication between pre-hospital care and the healthcare facilities can ensure minimal delay between injury and definitive treatment. Strength in number. Effective management of chest trauma care hinges on successful collaboration between different healthcare providers. The team approach, doctor, nurse, paramedic, and other trauma team member each play a vital role. By working together as a cohesive unit, information can be shared efficiently, decisions can be made quickly, interventions can be implemented. Regular team training exercise can further strengthen communication and the coordination within the trauma team. Leveraging technology. In areas with access to telemedicine technology, collaboration can be extended beyond the immediate team. Consulting with specialists in a remote location can be a valuable tool, especially for complex cases. A specialist can review patient information, X-ray, remotely, and provide guidance on diagnosis and the treatment plans. While telemedicine offers existing possibilities, it is important to acknowledge limitation in internet connectivity in some regions. However, the potential benefits of telemedicine should continue to be explored as technology infrastructures improve. With collaboration between different healthcare providers and potentially incorporating telemedicine, we can significantly enhance the quality of care. Community engagement. While effective treatment is important, preventing chest trauma in the first place are more important, and the timely care-seeking behavior are equally important. This is where public health play a vital role. Public education, community education programs, raising awareness about the risk and symptoms of chest trauma in communities can empower people to recognize potential dangers and take preventive measures. This could involve education campaign and focusing on road safety, wearing a helmet, using seatbelt, workplace safety measures for those in high-risk professions, and the proper child supervision to prevent falls. Education materials should be tailored to the local language and the cultural context for maximum impact. Training community first responder. Equipping community members with basic life support skills can be life-saving in the critical minutes before reaching the healthcare facility. This could involve training a program for recognizing chest trauma symptoms, perform CPR, control bleeding unit, improving ambulance services. Investing in well-equipped ambulance with trained paramedics can significantly improve the quality of pre-hospital care for chest trauma patients. This includes rapid response time, effective communication protocol between ambulance, crew, and healthcare facilities. Collaboration is the key. Public health are most effective when implemented through collaboration between healthcare professionals, government agencies, community organizations. By working together, we can create a multi-branch approach to prevent chest trauma. Key management strategy for chest trauma. Chest trauma remains a significant challenge. By focusing on these key approaches, we significantly improve the outcome. Resourceful adaptation. Healthcare provider in Africa must adapt management strategy to the limitation of their environment, emphasize the importance of clinical assessment skills, prioritizing interventions, considering alternative techniques when necessary. Golden hour, early intervention, rapid stabilization are important for improving patient outcome. Every minute counts. Focusing on rapid assessment, basic life support, minimizing the delay in reaching definitive care can significantly improve the chances of survival. Strength in collaboration. Effective teamwork among doctors, nurses, paramedics, potentially specialists by telemedicine is essential. Open communication and streamlined workflow within trauma team save valuable time and improve care coordination. Public health, investing in community education program, training first responders, strengthening pre-hospital care systems can play a crucial role in both preventing chest trauma and encouraging timely care-seeking behavior. By implementing these approaches, we create a comprehensive strategy. Conclusion. Throughout this session, we have explored the significant challenge. We highlighted the high prevalence and unique causes, RTA, violence, falls, leading causes in Africa, resource limitation, limited access to advanced equipment, specialized personnel, essential medical supplies, resource adapted management strategy by tailoring approaches to the available resources. Healthcare professionals can still deliver effective care. Early intervention, the golden hour concept, underscores the crucial importance of rapid assessment, basic life support, minimizing delay, collaboration, effective teamwork among doctors, nurses, paramedics, public health, community education programs, training first responder, strengthening the pre-hospital care system can play a crucial role in preventing and early intervention. By focusing on these key points, we can work together to improve chest trauma care, investing in resource development. The fight to improve chest trauma care in Africa is an ongoing journey. We have explored the challenges and solutions, but there is always more to be done. Here's how we can all play a part. Research and innovation. We need continued research on best practice for managing chest trauma in resource-limited setting. This will ensure healthcare providers have the most up-to-date knowledge and effective strategy tailored to their environment. Investing in healthcare infrastructure, significant investment is needed to improve healthcare infrastructure across Africa. This includes equipping hospitals with essential equipment like CT scanners and ventilators, expanding access to blood product and medication, and strengthening the pre-hospital care system, ambulance, and trained paramedics. Training and development. Investing in training program for healthcare professionals in Africa is crucial. This will equip them with the skills and expertise to manage chest trauma effectively, even with limited resources. Collaboration between African and international healthcare organizations can foster knowledge sharing and facilitate the exchange of best practices and potentially provide access to specialized care for complex cases. Whether you are a healthcare professional, researcher, or simply someone who cares about global health, there are ways to get involved. You can advocate for increased funding for African healthcare system, support organizations working on chest trauma research and education, or raise awareness about this crucial issue. Together, we can make a difference in the lives of countless individuals affected by chest trauma in Africa. Thank you for joining this webinar, for your commitment to improving global health outcome. Thank you for attending today. I appreciate your time and interest in this crucial topic. I would now be happy to answer any questions you may have about chest trauma. Please feel free to type your questions in the chat window. For further, please feel free to contact me. This is my email, omar@kasraeni.edu.eg. Thank you, everyone.
Thank you very much, Professor Omar, for this very insightful webinar. And indeed, it was really insightful with the knowledge and bringing all the package of what is really needed and what is involved in the management of chest trauma. So now we are going to call in for questions. If you have a question to ask to Dr. Omar, you are invited to raise your hand and you'll be given the question. But before we proceed, this topic is really dear to me because 2 weeks ago, my father had an accident where he sustained a blunt chest trauma. And access to management, though he was at the first level trauma health facility in the country, but there was still some delay at the level of management. Firstly, like what Dr. Omar mentioned, there was access to blood product was not there. For example, his blood group A rhesus positive, but blood was not readily available at the blood bank. And also access to fast imaging techniques like the focus assessment sonography in trauma and also CT scan was not really available because of all what involves management of trauma cases. So I think this is really a crucial topic that we need to really invest and advocate for policy making to increase trauma care. Thank you very much, Dr. Omar. Before I give the floor to those who have a question, I will ask, for example, in the case of a chest trauma, what would be the first imaging investigation that you will recommend in a given setting, for example, because certain imaging, for example, CT scan, which I think is one of the gold standard, is not readily available in some setting. So what do you think can be done in such cases?
The first important investigation in chest trauma, the clinical examination is the most important thing. No need to delay for further investigation like chest X-ray or fast or CT scan. In chest trauma, we think by history about the most critical things like pneumothorax, tension pneumothorax, hemothorax. We can use a needle to aspirate from the chest if we suspect hemothorax. By clinical examination, by using auscultation, we can hear the heart sounds, suspecting cardiac tamponade. We can hear diminished breath sounds. We can suspect tension pneumothorax. We can clinically suspect by hemodynamic instability, like low blood pressure, tachycardia. the most important thing in chest trauma, clinical examination. Then, if the patient hemodynamically stable, we can send him to imaging to make chest X-ray or CT scan.
Thank you very much for this insightful response. The keyword is the first investigation is the physical exam, and that will be my take-home message. So I'll give the floor to Adamu Isaka, who has raised the hand, then secondly by Victory. So Adamu Isaka, you have the floor.
Yeah, thank you very much, Dr. Omar, for a great presentation. I'm a thoracic surgeon from Ghana. I just want to know, we're saying like most of the centers is a trauma team. I want to know generally from what you've researched. Normally, when the chest trauma cases come, who attends to them? Is it the emergency physician, the thoracic surgeon? Is it the trauma team? How is the management like across Africa? That's my first question. My second question is to do with what's the rate of surgery, not the chest tube insertions. I mean operative surgery in chest trauma from your experience. Thank you very much.
Okay, the trauma patient, we can divide them into two categories, like blunt trauma, penetrating trauma. This is the big divisions. In blunt trauma, the thoracic surgery techniques limited only in hemothorax, esophageal perforation, aortic dissection, cardiac tamponade. We may need emergency department thoracotomy. In penetrating trauma, like gunshot or stab chest, there is indication also for emergency department thoracotomy, and there is algorithm I can upload to you if we need emergency department thoracotomy. Like when we insert chest tube, the chest tube have 1,500 blood immediately, or continued bleeding, hemoglobin drop, cardiac tamponade, tracheal bronchus rupture with hemodynamic instability, and the patient need for intubation. All these indication for emergency department thoracotomy. This is the approach we prefer, because if there is any trauma in the heart, we can extend the anterior thoracotomy to clamshell thoracotomy. Do you need any details, more details?
No, thank you for that. And then the second question.
Okay.
The second question was to do with who attends to the chest trauma patient.
In Egypt, in the emergency department, the first doctor who approaches the patient, the general surgery specialist. If he with the junior doctors, if he suspect he need cardiothoracic surgeon, he call cardiothoracic specialist. Then we intervene. If there is some delay, he go with the first step, like relief of tension pneumothorax, like that. In primary care centers, in the public of Egypt, no need for cardiothoracic surgeon in every hospital. The primary care in every region, the general surgeon can deal with the emergencies like pneumothorax, tension pneumothorax, hemothorax, and then refer to the more center and the tertiary care centers in the big hospitals, where there are every specialist, like cardiothoracic, neurosurgery, all other specialists.
All right, thank you very much.
Okay, Dr. Adam, you are welcome.
Thank you very much, Dr. Omar, and thank you very much, Dr. Adamu Isaka, for these questions and answer session. I'm going to give the floor now to Victory Efiom, which is the research director at the Association of East African Cardiothoracic Surgeons. So, Victory, you have the floor.
Thank you so much, sir, for the presentation. So, my question is, I know that when you have when you have chest traumas rushing in, you have to do quick clinical evaluation and the rest before, just as you said, before going to anything major. So my question is at the point where you're supposed to do surgery, let's say an emergency surgery or something, and you don't have and for such surgery, you need something, let's say you need to do a chest x-ray, and that's not forthcoming because sometimes most of these, like in a center, you have to keep, they hardly do like emergency, like it's not like something that when you rush the patient there for such thing, for getting such reports, you get it instantly or quickly. So in such situation, how do you guys how do you guys navigate such a situation? Do you guys go blindly to carry out that how do you call it, such surgeries? How do you guys handle such situation? Or how are we supposed to handle such situation?
Can you repeat the question?
Okay, so I said yes, I understand that when you have chest traumas coming in, you have to do a quick clinical evaluation, just as you said. Then with something basic, the pneumothorax thing, chest drainage, and the rest. Now, if it's something that requires like an emergency surgery, for a center where you hardly have um, you require something like X-ray and such enough for me because some 2 days, 3 days, or like to carry out such surgeries. What do you do in such situation?
If I may repeat, the question of Victory. Victory asks that as Dr. Mars said, the first thing to do is the primary clinical assessment. Now, he said in such a case where you receive a patient that needs emergency operation, and for example, there are certain preliminary investigation that you need to know to have a background of the extent of the trauma, for example, like a chest x-ray or even maybe a CT scan, and given that in most settings they are not available, how do you guys proceed with the operation? Do you guys just go blindly, or you have a special approach to which you consider? Thank you.
In these situations, we do the least possible intervention to achieve stability, then transfer the patient to a more specialized center. If tension pneumothorax or hemothorax, we insert chest tube, stabilize the patient, and transfer it in ambulance to the more tertiary center to advance to surgery. Not doing surgery blindly. We do the least possible intervention to achieve stability of the patient, then transfer the patient.
Thank you very much, sir, for your response. Victory, I hope you got the answer to your question. So now I'm going to give the floor to Hussein Khalif, whose hand has been up for a while. Khalif, you have the floor.
Thank you so much. Thank you, Dr. Omar, for a brilliant presentation. I wanted to ask about emergency department thoracotomy. In the African setting where resources are limited and most of the emergency departments are not well equipped and the blood is not readily available. What's the experience in Egypt? What are the outcomes in terms of success for emergency department thoracotomy?
If you ask about the factors about patient, the golden hour, the patient must come early as possible to the trauma center. If the prognosis in penetrating injury more hopeful than the prognosis of blunt trauma, because blunt trauma externally there is less damage to the body. Internally there is damage to more than one organ like heart, chest, liver. There is more damage. In penetrating trauma, like stab chest or gunshot, the prognosis will be more better than blunt. In emergency department thoracotomy, inpatient, if arrested in watchful arrest, if the patient come arrested to the emergency department, has more mortality than patient arrested in the emergency department and all the team are present and CPR are initiated and resuscitated well. The prognosis will be more better than patient who arrested in the route to the hospital. This is the answer. This is the most big difference between blunt and penetrating trauma. This is the most important division of the chest trauma patients.
Thank you very much for this response. I would like to emphasize that we have some of our mentors and senior doctors that are present during this webinar session, and from Ghana and Nigeria and all across Africa. So I would like to invite one or two to share with us their experience in terms of managing chest trauma in their setting, so that we have kind of an in-depth overview in each of these settings, so that
the sound was cut. Are you hearing me?
Yes, we can hear you. I think his network is not good.
There is any questions more?
Okay, so I think Frank was trying to invite some senior doctors that are here to share their experience on chest trauma in their setting. So I think we can start with, I don't know, can we start with Dr. Adamu?
Okay.
All right. Hello. So I think most of the statistics that Dr. Omar gave is similar to where I am. I'm based in the northern part of Ghana. and the northern part is a place where most often the means for most of the populace is using motorbikes. So in the RTA, we are not seeing like RTAs from vehicular accidents. It's more of the motorbike accident. So RTA actually is a one that is the top. If you mention, maybe we have like 90% of the motorbikes, and then when it comes the fall and the others are quite minor because there are a lot of farmers around. We have incidents, as he mentioned, with the violence or knife and other the cattle rearers. Also, some of them coming with a bullhorn in their chest. Most of our cases, when they come, while I was asking Dr. Omar, we here generally it's not it's the emergency physicians that see, and emergency physician not necessarily especially it can be a house officer, it can be a medical officer. So the next step, the person they calls is the thoracic surgery team, and then based on that we come, so the chest tube and all the other management, we are the ones who do them. Most often we teach all the those who come for rotations and other emergency to do emergency chest tube insertion. So when the patient comes and it's a weekend or late in the night, most often they will do the procedure. But when it's a weekday or within the normal working hours, most often they will call us to come and see the patient. And there have been several instances where, as he mentioned, for emergency thoracotomy, where we do like the incision immediate, we've done that only in one patient. Most of them we try to stabilize and then we go in for a planned elective surgery. So generally, that's what I have to add in case maybe there is something else that someone wants me to clarify. But generally, I think that the statistic has given it applies to us.
Okay. Thank you so much, Dr. Adamo. I don't know if there is any other resident doctor here or one of our mentors or senior doctors that's here. I also want to share their experience too. The floor is open. Okay, we are having the question here, Dr. Omar. The person said, he's from Mohammed Islam. How can trauma centers help for a better management of chest trauma? And is there an example of these centers in Africa? Hi, Dr. Omar, did you hear what I said? Did you hear the question?
There is some centers. There is examples of these centers in Africa. In Egypt, we have Qasr Al Aini Hospital. They make a specialized center for emergency, and any other new hospital, we do a separate department for emergency, and make an emergency team with a schedule attached to them. So emergency team. In Africa, there is some hospitals in Cape Town Trauma Center في South Africa, وكينيا National Hospital, University of College Hospital in Nigeria, Ibadan. This is data from Google. And in Egypt, we have many centers specified in trauma centers in universities, like CAIRO University and Shams University, Swiss University. In South Egypt, we have in every government trauma center in the hospital of the university.
Thank you so much, sir. I am Dr. Mohammed. I hope that has answered your question. Is there any other question before, or any other contribution before we end this here? Okay, I think in the absence of any other question, thanks so much, sir, for taking out your time to talk to us about management of chest trauma. We are deeply grateful and we really appreciate your time. Thanks so much.
You are very welcome. Thanks to everyone. I have a great honor to be do this webinar with you. I hope we can repeat this webinar in another topics.
Yes, surely we will.
Thank you
Thanks
very
so
much.
much.
Thank you very much, everyone. Thank you very much, Dr. Omar. Thank you, Victor, and thank you, everyone that is here. I would like to re-emphasize that we have a post-webinar survey that is going to appear immediately as we end the meeting. So each and every one of us is welcome to fill this survey. This will help us to improve our subsequent webinar session, and it will also help us to evaluate the impact of this webinar so that we have at least a progression in all our activities we are doing at the level of the Association of Future African Cardiothoracic Surgeons. So you are all welcome to join us, and we are going to have more webinar sessions coming up. And Dr. Omar, surely we are going to have several sessions that we are going to invite you to be our guest speaker. And it was really a pleasure having you. I think without further ado, we are going to end this webinar session, and have a great night and have a great day for those who are entering into the day. Thank you.